A Patient's Guide to Thyroid Surgery. Follicular Neoplasm. Hello. This is an educational video designed to improve your understanding and overall experience for your surgical treatment of papillary thyroid cancer. The goal of surgery. Thyroid gland is a butterfly-shaped hormonal organ located on your lower neck, which is anatomically divided into left lobe, right lobe, isthmus and pyramidal lobe. The gland secretes thyroid hormones which regulate many metabolic functions in your body. Thyroid cancer develops from a normal thyroid tissue. And, based on their cellular origin and microscopic findings, thyroid cancer is classified into papillary, follicular, medullary, or anaplastic thyroid cancer. Treatment options can vary depending on the cancer type. Fine needle aspiration biopsy is the gold standard evaluation for most of the thyroid cancer types. However, FNA biopsy cannot distinguish between a benign follicular adenoma from a malignant follicular cancer. Hence, FNA diagnosis of follicular tumor is simply referred to as follicular neoplasm. Therefore, follicular neoplasm biopsy result warrants a diagnostic thyroid surgery. For the surgery, if the preoperative evaluation revealed suspicious findings for cancer such as a tumor invasion or spread, a total thyroidectomy is performed initially, with a lymph node dissection if indicated. If no suspicious findings were present, only the involved lobe of the thyroid gland is initially removed. Once the thyroid specimen is out, pathologist examines the tumor under the microscope for any signs of cancer such as tumor spread or invasion of surrounding tissue. If the diagnosis is benign follicular adenoma, no further treatment is needed. If a cancer diagnosis is confirmed, patient will require a completion thyroidectomy to remove the rest of the thyroid gland. Procedures. Thyroid surgeries are performed under the general anesthesia. Once the anesthetics are administered, patient is positioned for the surgery and skin is prepped and draped in a sterile fashion. Thyroid surgery is typically performed via a low neck incision. Once the thyroid gland is exposed, the gland is carefully dissected off from the surrounding tissue and blood vessels. Based on the preoperative clinical suspicion or intraoperative findings, the patient may require a total thyroidectomy, with a lymph node dissection if indicated. If no suspicious findings are present, only the involved lobe of the thyroid is initially removed. Once the thyroid gland has been removed, all blood vessels are carefully coagulated. Then the wound is closed with a temporary drain in place to monitor and minimize fluid accumulation underneath the skin. The resected specimens are sent to the pathology department to be examined for various factors including surrounding tissue invasion, tumor size, and spread to regional lymph nodes. Post-operative care. To avoid pulmonary complications after the surgery, patients are encouraged to perform deep breathing and coughing exercises. As the anesthesia wears off, patients may experience an incisional pain, sore throat and neck stiffness from the surgery, breathing tube placement, and neck positioning. However, these symptoms are often well tolerated with pain medications and often resolve in few days. If a drain was placed, it is routinely removed prior to discharge once the output had decreased and the drainage has cleared. Please be careful not to accidentally dislodge the drain or kink the tubing while sleeping or moving. Post-operative treatment plan. After a total thyroid resection, patient will require a thyroid hormone replacement therapy. This will provide physiologic dose of thyroid hormone while acting as a suppressive treatment for thyroid cancer recurrence. Also, depending on the stage of cancer, patient will require a radioiodine therapy to destroy cancer cells remaining in the body. Complications and side effects of surgery. bleeding. Your neck has abundant blood supplies with extensive blood vessels. And despite a meticulous bleeding control during the surgery, it is possible to have a delayed bleeding complications. Bleeding in the neck can pose a serious breathing problem, given that the tense buildup of blood can obstruct the airway, which would require an immediate surgical evacuation of blood and bleeding source control. However, such bleeding complications rarely would require a blood transfusion. Wound complication. Rarely the neck wound gets infected with swelling and redness or sometimes with an abscess formation, which will require appropriate treatment. Also, certain patients with predisposition may form a keloid scar at the incision site. Nerve injury. Vocal cords are located in the larynx, and their function is controlled by the recurrent laryngeal nerve, as well as the superior laryngeal nerve. These nerves courses right next to the thyroid gland, and can be injured during the FNA biopsy or thyroid resection. Nerve injuries may result in voice changes and hoarseness, but majority of such injuries are temporary, although in rare cases permanent. In case of simultaneous left and right nerve injuries, the patient may experience breathing difficulty due to the lack of normal vocal cord movements for breathing. In such cases, a separate procedure known as tracheostomy may be required to gain a direct access to the airway by inserting a breathing tube directly in the trachea. This temporary access will be discontinued once the transient nerve injury recovers. Lymphatic leak. Neck also has an intricate and extensive lymphatic drainage system. Thus, thyroid surgeries or lymph node dissections may result in lymph vessel injuries and leaks. Most of the lymphatic leaks are self-resolved and does not require any specific treatment. However, in certain cases of high output leaks, especially after an extensive lymph node dissection, the patient may require an ongoing drainage or even a surgical treatment. Hypothyroidism. Thyroid hormones stimulate metabolism in your body. Thus, elevated thyroid hormone level causes symptoms of hypothyroidism, while diminished level causes symptoms of hypothyroidism. Once the entire thyroid gland is removed, no thyroid hormones are produced in your body. Therefore, thyroid hormone replacement therapy is required to prevent hypothyroidism and also to suppress thyroid cancer recurrence. Meanwhile, in case of a partial thyroid resection, your thyroid function is usually preserved. However, sometimes the thyroid hormone replacement therapy is still given to suppress the thyroid function and tissue. Hypoparathyroidism. There are 4 parathyroid glands located on the undersurface of the thyroid gland which regulate calcium level in your blood. Only one parathyroid gland is required to maintain normal calcium homeostasis. However, thyroid surgery may compromise the blood supply to all parathyroid glands and may result in hypoparathyroidism. Furthermore, parathyroid glands are sometimes inadvertently removed or dissected off along with the specimen, especially when the parathyroid gland is embedded within the thyroid gland. When the parathyroid hormone level drops, your blood calcium level also decreases, which may cause numbness and tingling around your mouth and hands. Your symptoms may progress to muscle spasm and cramps. These symptoms are usually treated with supplementary oral calcium and vitamin D to improve your symptoms and calcium level. Hypoparathyroidism occurs in about 20 to 30% of the patients, usually 1 to 2 days after the surgery, and may last for 2 to 4 weeks. Hypoparathyroidism is usually temporary, but in rare cases it may be permanent. Cancer recurrence. Despite of appropriate thyroid cancer treatments, including complete resection of the thyroid gland, Thyroid cancer may recur down the road from a microscopic residual cancer cells. The rate of recurrence is dependent on the initial stage of the cancer, and therefore, appropriate treatment plan and strategy is important. Alternative treatment options. Thyroid cancer treatments include surgical, hormonal and radioactive iodine. Currently, surgical resection of the involved thyroid gland is considered to be the main treatment option. In case of a diagnostic thyroid lobectomy, if the final pathology confirms cancer diagnoses, you will need to undergo a second operation to completely remove the thyroid gland. Despite of comorbidities associated with a redo operation, some patients prefer to have thyroid lobectomy in order to avoid lifelong treatment of thyroid hormone replacement therapy, which would be required after a total thyroidectomy. Patient's preference as well as the clinical indication should guide the decision-making process. This concludes the educational video on thyroid follicular neoplasm treatment. Thank you.